Hi, Dr. Sambit. Hello? 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 Yeah, Dr. Sambit, can you hear me?
Hello. Hello.
Hello?
Hi, good evening.
Good evening, how are you?
Good, good. How are you doing?
I'm fine. Your voice is a bit low. Your volume has to be up a bit
Okay,
slightly.
let me just check that. No, it's 100%. The volume is 100%.
Yeah, fine, great. Can
Is
you
it
have your
still low?
video? No, it's fine. You just have your video on.
Okay. You mean my camera?
Yeah, your camera,
Okay,
yeah.
yeah. Cool.
So all set, should we start?
Yeah, I think we should start.
Okay, your camera is still not on, is it?
Yeah, I think it's on now. I'm like sitting on the floor, so I deliberately.
Okay, doesn't matter. You can keep it off. No issues.
Okay. No, but
As
it's fine.
as
Yeah.
you are comfortable, no issues.
Okay.
Okay, so we start, right?
Sure, sure.
Right, great. Good evening, everybody. Welcome to this evening episode of Pursue. And this is Pursue 2H, which is lymph nodal pathology. We are streaming live from AMRI Bhubaneswar via Kolkata. Today we have a very interesting topic and a very accomplished pathologist to address the topic. The topic is lymph node for general surgical pathologists, something which we all really need to know. And that's a real problem for all of us, a case-based learning. And to talk on that, we have Dr. Sambit Mohanty, who's an MD from PGI Chandigarh, MD USA, FRCPath, FACP Diplomate of American Board, State University of New York, clinical fellowship training in Oncologic Surgical, Women Health, Urologic, Digital and Molecular Pathology from centers like UPMC, Johns Hopkins University, NYU and Cedars-Sinai Medical Center. More than 100 publications in national and international journals. He's a nationally and internationally acclaimed and US board certified anatomic and clinical molecular digital pathologist. He received the record number of distinction and 12 university gold medals in his MBBS from SCBMCH Odisha, did a residency from PGI Chandigarh and then from the State University of New York. The clinical fellowship training in Oncologic and Surgical, Women Health, Urologic, Digital and Molecular Pathologies with more than over 100 publications, multiple chapters and books, and a number of invited presentations in ASCO, USCAP, AD, ASDP, CAP, and ASCP to his credit. He is also the reviewer of board of a number of international acclaimed pathology and oncological journals. His research interests are primarily on genetic and neuroendocrine breast cancers, molecular profiling of genitourinary and gynecological malignancies, and lymphoma. Currently, he is the director of the Oncological Surgical and Molecular Pathology at the famous AMRI Hospital, Bhubaneswar. With this, before I ask Dr. Mohanty to take over, let me request you to keep your mic muted, your camera off, and please don't share your screen. With this, let me ask Dr. Mohanty, sir, please share your screen and let us start. Just press present now and your entire screen. And press in the center and share.
Is my screen
visible? I can see your screen. Please make it full screen, please.
Okay, good evening everyone, and
just press that hide thing so that pop-up just goes away.
Okay, cool.
Yeah, cool.
So good evening guys, and good evening everyone who is in the who is kind of listening to me. And thank you, Nadinda, for this excellent uh, kind of introduction about me, which I probably doesn't deserve. Anyway, so thank you. And lymphoma is one area I am probably the most weak in. Out of breast, GU, GYN, and all, and molecular pathology, lymphoma I know the list. So I thought let's attempt to cover lymphoma, whatever I know, in a single class. So these are the people with whom I work. So at different centers. So I kind of dedicate and acknowledge them for this presentation. All of them, they helped in giving their cases. I basically what I do, they are all lymphoma people. I help them sometimes whenever there's some difficulty or there is a reporting issue and how to go about it, as purely as a general surgical pathologist. So let's start with a few cases. The first case is like a 15-year kid with fever, weight loss, and night sweat, with multiple cervical lymph nodes. The bilateral cervical lymphadenopathy and peripheral blood findings are normal. ESA was mildly increased. LDH wasn't done in the beginning, but the history was like fever, night sweat, and weight loss with bilateral cervical lymph node. The largest one is about 2.5 centimeter. So what we have on H&E, this I borrowed from Manas. I mean, I was involved with him, but he was a primary pathologist. There was complete effacement of the nodal architecture. It was completely gone. There was no residual follicles. And instead, we have a very diffuse pattern of polymorphic involvement. What I mean by polymorphic, what I see, you have these big cells, which are kind of standing out, even in the lowest power. This is a medium power picture. And we have other cells making the majority of the lymph node. The major 90% of the cells are the cells which are in the background, and these big cells are popping up. Some are binucleated, some are uninucleated, some having this irregularity of the nuclear envelope. The chromatin is coarse, some prominent nucleolus in some of these. This is the binucleate and some eosinophilic cytoplasm. And if you see, you have a typical cell with prominent nucleolus, eosinophilic, and perinuclear clearing, cytoplasm. This is another one, this is another one, and this one, it looks like as if the nucleolus is gone with some chromocenters. So, I mean, I would not jump to a diagnosis of Hodgkin looking at this. I can show you a Rich-Sternberg cell and its variants in virtually any malignancy. So looking at these cells, for everyone, all of you in the group, and particularly for the trainees, the residents and the fellows, do not jump into a diagnosis of Hodgkin when you look this kind of cell. You say like it's a classical Hodgkin cell, and that was when we are in the training. The differential are less, and people are not aware of all these entities, and the discovery was still going on way back in 1995, 96. So I thought it's the polymorphic infiltrate, and I have these big cells, and the cells in the background, they're plasma cell, lymphocytes, some endothelial cells, some eosinophils, and some histiocytes. So what I did, when I get this kind of thing, I try to like my first panel. I'll go in a panel approach, and this is another area where it has a cord-like arrangement. The cells which are I would not say bystander right away because they may not be bystander. I haven't done an immuno yet. These are the inflammatory cells in the background, plasma cells, follicular center cells, and all those, and histiocytes. They're forming cord-like arrangements and clustering, and you have some multinucleated cells as well, and some uninucleated with two nucleolus, multiple nucleolus. So all sorts of aberrations were there. So I'll show you another case with a similar kind of history. That was a 15-year-old male, and this is, so in that case, it was not difficult. So I did a 45 LCA and a PAX5 to begin with. So my 45 were dead negative in those big cells, and the background cells are 45 positive. The B cells in the background are strongly PAX5 positive, whereas these large cells, they're so weak and barely perceptible, very wishy-washy kind of PAX5 positive, which are weak. So that basically helped me. So those are cells with aberrant follicular um, or post-germinal center differentiation. So they are not expressing 45 and the PAX5 dim, they're negative for 20. The background cells are 3 positive, big cells are 3 negative. ALK, anaplastic large cell lymphoma kinase, was negative, and the cells are 15 and 30 positive. CD15 and CD30 has Golgi zone perinuclear dot-like positivity. So that confirmed my diagnosis, the classical Hodgkin lymphoma. Do not use the word Hodgkin's, it is Hodgkin lymphoma, and there's no apostrophe S, so that is something to. And we are not using the word Hodgkin disease now, it's saying Hodgkin lymphoma. So it was a 1530 positive, 23 negative, ALK negative, 45 negative, and PAX5 dim, EBV LNP positive, classical Hodgkin. So what's the big deal? Why I'm showing this case? Let's go to the next case in a similar theme. Is a 52-year-old man with intermittent fevers and night sweat with a chronic cough. A PET CT showed a enlarged left supraclavicular lymph node, and there was another lesion in the left lobe of the liver with multiple bulky retroperitoneal lymph nodes. Peripheral blood smear were normal, except for anemia, which was again normochromic, no blast, no abnormal cell. So they went ahead and did an excision of the left supraclavicular lymph node. So what we have in this lymph node? This is not a capsule. This is a tract of fibrous tissue which is present, and this is dividing further the lymph node into multiple nodules, and the varying size nodules. The nodule has a dark periphery and a pale center. And this is the paler nodule. You see these big cells from this far as well, and some small cells. This is more mottled. What I mean by mottled, they have a shades of white and blue, or pink and blue, and this is like a blue area. And again, we have broad bands of fibrosis, which is kind of dissecting out the lymph node into multiple nodules and further dividing the nodules into different small nodules. These large cells, some having hypochromatic nucleus, and this lymphoid tissue. So this is a no-brainer again, the same thing. We have, what's the big deal? So we have a lot of these cells. As compared to the last case, here the number of these uninucleated, binucleated, and multinucleated, ugly-looking bigger cells are a lot. And we have some lymphocytes. What is important? When I'm kind of looking at that lymph node, which was an old case, I saw some of these follicles. Like this one is one. And sorry for this scoring mark. And there is another one. There's a fold there. And there is another one. And this is the nodule with those large cell and polymorphic background. So when I look at this is something like where the concentric kind of lymphoid tissue, and there's a little pale, tiny center. Same thing here, same thing here. So what's going on? I was like more curious about this area, forgetting about this area. So let's see what's happening. This is at a high power. If you see, this is concentric. This is the marginal zone, the mantle is the follicular center. The mantle is always dark, to remember, for the neophytes in pathology. Mantle is the dark concentric area of cells. Marginal zones, they do have clear or eosinophilic cytoplasm. They are polyhedral to polygonal. They are about 2 times the size of mantle cells, and follicle cells are again bigger, they're intermediate. So the periphery is, the marginal zone is pale. Excuse me. Hello?
Hello, Doctor.
I am actually in the middle of a class. Can I talk to you later?
Sure, sir. I just want to get on track.
So, so in the periphery we have, so in the periphery we have this bigger cells and center. But look at this center, which kind of, and if you see, this center is pale, and there are some paler cells which are kind of getting into this area, and this is very tightly packed. I was not very comfortable kind of naming it as a reactive or a residual follicle, so I don't know, somehow my brain was stuck. Again, if we go to further high power, these are the follicular center cells with some nucleolus. These are the two nucleolus. And if you see, these cells are kind of traversing. They're going in between. They're going in between towards the marginal zone or the mantle. But this follicle sort of is not looking healthy to me. So opinion. So can I have some opinion? Other than the Hodgkin. I think that one is a Hodgkin probably, but we'll talk about it. I do not know yet. So any opinion from the house, from the audience?
Let's wait and see.
Can it be Castleman just?
That's a very good thought, Castleman. But I had only 3 follicles, and to be very honest with you, is it Pulkit?
Yes, Pulkit here. Yeah.
Hi, Pulkit. So there was only 1 follicle like that, and the other 2 I was kind of more extrapolating, but when I went to high power, I did not see that. And the follicular center, as you said, was not exactly athletic. I did not find any vessel getting into it, but that's definitely a good thought. And do you want to do any stem to kind of know what is the nature of that follicle? But that's definitely a great thought. Pulkit, do you want to do any stem to kind of chase after that follicle?
Yeah, at least 320 BCL2 and CD30.
Okay, those are would be done. So BCL2 definitely you will do. But in a classical Hodgkin lymphoma with this kind of histology, we do go for a BCL2. If you're 30, 15, and 45, FACP, they're all behaving in the right way, would you go for you not go for a BCL2? But with this kind of thing, you'll probably go for a BCL2.
Yeah,
right?
definitely for this follicles.
Great. So this is my 20. 20 was highlighting quite a few cells in this, the big cells and small cells. These are basically, I took this picture from the large cell areas. This is my 3. 3 was staining some of the cells, not up to the tune of 20, but maximally these cells are positive for 30, then 15, then 20, then 3. And some 3 positivity were Golgi zone kind of positivity. And this is the 30, which is again beautiful dot. And this is my 15. This is FACP, which has a heterogeneous kind of staining, some which is kind of completely washed up, some intermediate, some dark, maybe the regular bystander B cells, and some having intermediate kind of staining. Okay. This is my mum 1. This is OCT2. Bob, EMA, and Ish were negative. I did some T cell antigens here, like 4, 5, 2, 7, and 8. And they showed some sort of positivity, a variable degree range of positivity in those big cells. 20, I just showed you, now I'm focusing on those follicular areas, those 3 follicles. Mainly I'm focusing on this one, a 20 positive, 3, there are few 3 positive cells in the center, but majority are negative. 10 was positive, and BCL2 was high. Not this one, this 2.
Hello? Hello? There is some link problem at Dr. Sambit Mohanty's end. I'm just waiting for him to rejoin.
Hello.
Yeah, we can hear you now.
Yeah, I think I lost my connection. I'm so sorry for that. And
Yeah, I
which
think
slide? Which slide was it?
you go to that complex slide pattern which you were showing, 4 in 1.
Diathesis?
Yeah, the IHC ones, yeah. Just go ahead, go more further up. Yeah,
This
this
one?
one.
Okay.
Yeah.
So I'm sorry,
You can
guys.
just
Like,
press hide so that
yeah,
that
yeah,
will.
sure. So
Yeah,
these
great.
cells, they're positive for T cell antigen, except for CD7. They're positive for 5, 4, 2, and 8, and they're positive for 3 as well. And changing after that nodule or the follicle, the type, the follicle with that concentric thing, is for express BCL2 in the center. They're positive for 10 and 20. And the negative stands when the large cells for LCA, ALK, PD1, 7, beta F1, TIA, granozyme, and pancytokeratin. So IHC-wise, the large cell immunoprofile was compatible with the classical Hodgkin, and some of the large cells express T cell antigen except for CD7, and it is kind of well documented the positivity for T cell antigen in Hodgkin, and the small the follicles, they show the features of in situ follicular lymphoma, which are confirmed by fish assay. Flow cytometry shows a small population of kappa restricted cells that are positive for 20, 19, 10, and BCL2, and they're negative for CD5. So I would not be wasting my time going much into the flow details. I'll just quickly show you the 19 and 10 positive, 5 negative cells, and the kappa restricted, and 20 positive. On a molecular way, the immunoglobulin heavy chain and kappa light chain reveal patterns suspicious for monoclonal rearrangement. There was no clonal rearrangement involving the T cell, beta, and the gamma chains. So the diagnosis given by the Hodgkin lymphoma with in situ follicular lymphoma. Any question? Yeah.
Yeah, I have a question. So, why is not a gray zone between classic Hodgkin's and DLBL? Because MUM1, I think the PAX5 was not weak positive; it was pretty of
No,
moderate to strong.
I actually deliberately showed that picture. I was deliberately to distract. I put that picture of PAX5 where the big cell staining was the maximum. Majority of the big cells have very weak, wishy-washy kind of staining. This is the only area. I took this picture from this area just to distract everyone, and I'm glad like you asked that question, why it is not a gray zone or why it is not a like a high-grade B cell lymphoma, which is rich in T cells and all in the background. Yeah. So deliberately I just, because sometimes in a Hodgkin, though the majority will show this weak or barely perceptible kind of positivity, and some foci we do see PAX5 being little more stronger and comparable to the background B cells. So we tend to call those as these are B cell lymphomas. And here another thing is we have a CD20 positivity. The thing is these cells are 45 negative, though 45 negative B cell lymphoma is well documented. I also did a CD79A in this and a CD19, the both were negative.
Okay.
Because I did have that question. Is it Vishal?
Pulkit only.
Pulkit, yeah. Exactly the same question. I never thought of a Hodgkin in the first go. I was almost on the verge of signing this case as a Gray Jones lymphoma. I was not confident enough because at the more and more stain I was doing, and I was like all over the place, and this T cell aberrancy was coming into play. We had the so a lot of things going on in this. 10 was negative, and so that was the story. But this is the only focus which has the maximum PAX5 strength in the entire slide. So I deliberately put, and this focus kind of took 4 days of mine to finalize the case. I was sitting on the case every day before I finalized what to do. Hodgkin was the last in my brain. Okay, great. Let's go to the next one. So this is one thing I just want to, let's say, most of you know that these are Hodgkin and follicular lymphoma occurring in the same patient, providing some insight into the pathogenesis of the disease. The finding of shared immunoglobulin genes in Hodgkin and follicular lymphoma in this case shows that they are derived from the same precursor B cell. Additionally, these two tumors contain common and exclusive VH gene somatic mutations, demonstrating that these precursor cells were of germinal center phenotype and these mutations are only introduced in the germinal center reaction. They also showed continuing somatic mutations within the immunoglobulin gene, rather those are somatic rearrangement of the follicular lymphoma, which is typical, and it is likely that the precursor B cells in each case underwent a transforming event that was shared by both the tumors, and when additional transforming events specific to each tumor subsequently occur. So let's go to the case 2. Case 2 is, I have to make up the history. I'm sorry, I really do not remember. It's a cervical lymph node that I remember, and the patient is a 50 or 60-year patient. So what we have here, there is perinodal extension of the disease. There's a thick capsule, and the lymph node is more or less completely effaced. So what we have these blue areas with small nodules. There are some residual follicles, some focally, and we have these pale cells. And there are some areas which look like pseudoalveoli-like pattern. Some areas the cells are packeting. They have prominent nucleolus. They are big cells, and they have intermediate to bigger cells. Majority having prominent nucleolus. Some with some, and most of the nucleus, some are center and some are eccentric. Some are going to the nuclear membrane, attached to the nuclear membrane, vesicular chromatin. Some look little modified. Brisk mitotic activity and apoptotic bodies. Cells with this packaging kind of arrangement is also seen. Some pseudoacinar pattern was also seen. So when I work it up, I did a pan-CK. To begin with, it was negative. And I did not do a 45 in this case in the beginning. I did a CD20 and a 3. 20 was negative and 3 has a very, very bystander scattered T cell pattern. Then I thought, let's me do a 45. 45 was strongly positive. So we have 45 positively. So I know I'm dealing with a hematolymphoma neoplasm probably, but it's 20 and 3 negative. All my T cell markers were negative. PAX5 was wishy-washy and CD79A was very poor. I would say only 10% of the cells are strong. Those big cells were 79A positive. So I thought probably I'm dealing with a T cell neoplasm. My 19 was negative, CD19. And it was a neck area, the lesion. I had a wild thought of probably I'm dealing with a Merkel cell. I did a 20, CK20, which was negative. TDT was negative. Regarding thinking about something, a granulocytic granulocytic sarcoma, MPO 34 and 117, they're all negative. Peripheral blood smear film was negative. So what is the next step? How to work it up? I'll show you the stains.
C38, 138.
38. I did not do 138. I did 38. 31 was negative.
Okay.
38 has, there are some plasma cells which were positive in between, like CD3, but it was largely negative.
And ALK.
Okay, great. You hit the point. I'll show you. This is the ALK. This is CD30. This is 3. This is your 20. This is BCL2. I'll show you the best ALK here. This is your ALK. So what is the diagnosis?
ALK positive DLBCL.
Yes, this is ALK positive DLBCL. I signed it out today. I took the pictures in a rush. So they are not that great. Okay type. Okay. And this is your KI67. So the third case, I will not probably go for the third case in this. I'll go to the next one. Yeah. So it is a 41-year-old male with a swelling and ulceration in the uvula and soft palate. And this is my case slide. This is not from the same case, the similar case. So they look different. So this is the epithelium, the overlying epithelium. What do you have? You have some pending necrosis, some neutrophils, and some nothing spectacular in this part. And here we have an infiltrate. What is more important more important to the infiltrate is this eosinophilic areas which in between. I kind of give a lot of importance to this area because of ulceration. There is some fibrin and a granulation tissue formation. But in addition to big cells, which is kind of hiding within this infiltrate because it's composed of neutrophils as well, and we have this vascular problem. And same thing, you have neutrophil, nuclear dust, and these cells, some cells having some cytoplasm, moderate, some having little cytoplasm, they're hyperchromatic. These are endothelial cells, the cells with the vesicular nuclei. I would say not vesicular, they're kind of a smudgy nucleus, and this big cell. And these are the normal ducts, and they are kind of expanded. The stroma is expanded in between by this cell. They have a size of about 1.5 times that of small mature lymphocyte. Nucleolus is not readily visible. Nuclear membrane is sort of irregular, and they're hyperchromatic. And some cells, focally, there are cells with vesicular nucleus, prominent nuclear, and look at the nuclear envelope irregularities here. And they are kind of surrounding these normal structures without involving them. Maybe one is going in, but majority are not involved. They are like kind of draping around it with prominent nucleoli and all. They're involving a vessel, artery. This is from another case, not from the same case. So, any thought?
NK cell lymphoma?
Okay, that's a differential. Anything else?
Granulocytic sarcoma.
Okay, anything else?
Lymphomatoid granulomatosis.
Yes, great. Anything else? So you want to work it up, right? Do you guys think anything benign in this case? And honestly speaking, when I looked at the case, I could not see the mitosis that readily. It was not, in a thinnest section also, mitosis were not readily discernible. So anything benign you think in this case? I mean, you all are in the differential, great differential.
Vasculitis.
Yeah, that's a possibility. Great. Let's see. So this is
EBV
my
positive mucocutaneous ulcer types.
cool. Great. So my audience is really brilliant. I'm kind of learning a lot. I'm scared. So this is your 3. The bottom one is 3. The top one is B. 20 and 3. This is your CD2. 4, sort of lost. Very few 4 positive cells. 5 is intermediate. Some positive, some negative. 7, more or less. I mean, less than 5, more than 4. Way less than 2 and 3. This is your 8. This is your 56. This is 57, which is negative. EBV, nuclear positivity. So I find it out as a nasal type T-NK cell lymphoma. Am I correct, Pulkit?
Yes. What is the state of CD30 and any cytotoxic TIA granzyme?
Yeah, I'll show you that picture.
Yeah.
The CD30 was negative.
Okay, so just to rule out ALCL as these can be
Yes.
confusing.
Or like a CD30 positive lymphoproliferative neoplasms. You
Yes.
mean to say lymphomatoid, those spectrum regions. Yeah. So, and I'll show you that. So in this case, I'm sorry, I did not have the picture of TIA and Granazyme B. I think TIA was positive, and Granazyme B, I have to check and get back to you. These are old slides, so I have to but TIA was definitely positive. at that thing. So the next
Sir,
one.
you asked us to think. Sorry to interrupt. You asked us
No,
to
no.
think something benign, sir.
Yeah.
Anything in particular you wanted to discuss, sir?
Because the history is like it is in the uvula, in the soft palate. So I would kind of thinking people will ask me whether anything in the lungs or anything in the paranasal sinuses, like vaginous kind of thing, because you do see angiomatous vasculitis and sometimes the epithelial histiocytes and the garden variety of histiocytes, they show a lot of ATPs. So I was giving some hint like I did not see any mitosis, there was ulceration. So you do always think about something benign might present like this instead of jumping directly into a malignant pathology. Okay. So the
Thank
next
you, sir.
one, is a 72-year-old 72-year-old female with an intraventricular mass. So it was the patient had progressive hearing loss over the past decade and recently developed with pain in the left ear and the face. The patient had a history of migraine most of her adult life, and a facial examination and the facial muscle and sensation symmetry. The hearing was intact to finger up bilaterally. MR revealed an enhancing mass measuring 2.6 centimeter into 1.6 to 2.1 within the left lateral ventricular atrium. Compatible with intraventricular meningioma. That was the thing the radiologist told me. There was increased perfusion and blood volume within the mass. I did not understand this intraventricular meningioma honestly. I did not ask much. And surrounding conferring T2 hyperintensity suggestive of vascular edema. The patient underwent a craniotomy and tumor excision. During the surgery, it was noted that tumor was rising up from the choroid plexus. And an intraoperative consultation was done and debulking was undertaken. So this is the lesion, the white area. There. This is what the intraop. So who can help me with the intraop? Any residents or fellows in the group? I mean senior resident and residents. This is the intraop frozen section, right? So we have a monotonous blue cellular proliferation. That much I can see from this part. And this is the next part. What are these cells? Any resident or fellow?
Sir, lymphoproliferative neoplasm could be suspect some disorder.
Okay, Silpi, you look at the cells. Do they look? I mean, it looks more like a non-neural tumor. It doesn't look like neural. It looks something different. And as you said, it looks more lymphoproliferative. Okay, can you be more specific?
I don't see any glial background, sir. Fibrillary
no glial or neuropil, nothing like that. And if you see there's no meningothelial differentiation, as the MR person said. How about the cells? Do you want to be a little more specific? Maybe favor something to the neurosurgeon while doing a frozen section? They're kind of eccentric, like the nuclei.
Plasmacytoids, sir.
Yeah, they look plasmacytoid. Very good. Let's see the next one. So the CD20 was, some of the cells are 20 positive. This was not my case. I inherited from somebody else. I don't have all the slides. I can give you all the information in this. This is 3. Okay. This is 138. 38 was also positive. And KI was 15%. There was kappa light chain loss. And majority of these plasmacytoid cells were positive for IgM and IgG, and few were immunoreactive for IgA. And in situ for EBA-ish was negative. So I gave a diagnosis of primary CNS lymphoplasmacytic lymphoma. Not I, my colleague. So do you guys think is the correct diagnosis? I mean, I am nowhere. I cannot say it is correct or incorrect, but I just need help from the house. Is it lymphoplasmacytic lymphoma?
Sir, what is the HIV status of the patient, sir?
I do not know. I have to ask. I do not know the HIV status.
Have you performed MYD88?
No, it was an old case, Pulkit.
Okay.
It was, I guess, 2017, 16 or 17 case.
Dr. Sridhar Patil on the YouTube has said, can it be an angiosarcoma?
What was the question?
So Dr. Sridhar Patil, he made
Uh-huh.
a comment on your slide saying, can it be an angiosarcoma?
On this one?
Your CNS lymphoplasma sarcoma.
Okay. 31 and 34 were not done. We didn't think about an angiosarcoma in this case. This is all the 3 positive, 20 negative. I mean, some are 20 negative, 20 positive. 138 was strong, and there was lambda positive kappa loss. So they are plasmacytoid. So why it is not a myeloma? Other than diffuse B, large B lymphoma, lymphomas manifesting primarily in the CNSR, they include low-grade B-cell and T-cell lymphomas. And primary CNS low-grade B-cell lymphomas almost exclusively affect the adults. They present with seizure, visual defect, focal neurological deficit, and around memory impairment. There is no association with immunodeficiency except in rare cases extranodal marginal zone lymphoma or the mole lymphoma. Primary CNS lymphoplasmacytic lymphomas are even rarer. It is critical to confirm a neoplastic process, not a chronic inflammatory process. This is very important. So we need to get into more and more detail. To separate the LPL from other low-grade B-cell lymphomas, including small lymphocytic lymphoma, mole lymphoma, and follicular lymphoma. By its definition, LPL does not fulfill the criteria for any of these small B-cell lymphomas which are given below. That may have some degree of plasmacytic differentiation. A small lymphocytic, mole, follicular, they all can show some degree of plasmacytic differentiation. Because the distinction between LPL and these other lymphomas, especially the multi-concept lymphoma, is not always clear-cut. Some cases may need to be diagnosed as small B-cell lymphoma with plasmacytic differentiation, and a differential diagnosis is provided in the report. There are no set guidelines for treatment. The treatment has varied widely and has included complete or partial resection, steroids, radiation, chemo, and combination of this, despite there is little evidence that adjuvant chemo and radiation will increase the chance of cure. The result is not very promising. The treatment is basically aimed at controlling the disease process and prevention of the end organs, and there is no known benefit to early treatment when the presence are asymptomatic or without end organ impairment. So you have like lymphoma experts in our group, so I really need some opinion on this case. I put this case because I needed opinion.
It can be that extra osseous plasmacytoma. Why it can't be plasmacytoma just?
Exactly, that was my question. Why, for that reason I make this. Why it is just not a plasmacytoma?
So
Why, I mean,
I think the only thing that can sort is you can do mid-88 over the blocks, and yes,
we do have the blocks. That is going to help.
Yeah, that is going to help. Plus the serum parameters as well. Since I think this has IgM type, so which
IgM type.
Yeah, you can check the electrophoresis, serum electrophoresis for that thing, and also the myeloma associated fish recurrent genetic abnormalities. If they are present, they help in distinguishing LPL versus myeloma.
I think there was a bone marrow following that. Okay, the bone marrow was negative.
No. We can do. You can do on this section as well.
Okay, you mean the fish and the tissue paraffin block? Yeah, I mean
definitely. It helps. It sometimes helps us.
It helps. You mean you're looking at the all the translocation involving the immunoglobulin heavy chain and also
11, 14, 14, 16, yes.
13q deletion or
1q gain. 1q gain.
Yes.
Yeah. So
I mean, we do have that. We do it for the bone marrow aspirates regularly with the 138 magnetic bead and thing. So that can be done. How about the CD3 positivity? Just few.
It might be in the background T cells. So many times in low-grade lymphomas, we do see a lot of 3 positivity in the background
No,
T
the
cells.
cells which are positive, they are all 138 positive and they are like plasmacytosis.
You should get one MUM1 also positive. I think you have done only one lineage of this 138.
No,
Yeah.
MUM1
That's
was
good.
positive. MUM1 was positive.
So
I
then
don't have all the slides. I in a rush. I took the picture.
okay, okay.
So my
Then
question is about this three. Is three positive is an aberrancy? It can be an aberrancy, right? Because three positivity is known. I have few reports on three positivity in neoplastic plasma cells. So I have never seen. So it was my question to the house: can we get three positivity? If anybody has experience, I have no experience.
I think three is a lineage marker. Other aberrancies are known, but not the three.
Three is a lineage marker, and so lineage marker hardly there's so aberrancies. So
Yeah,
that is the thing.
yeah. You can also add the gene rearrangement IGH and TCR for the same.
You're right. The block is there, so a lot can be done. Thank you, Pulkit, and thank you all of you. Okay, the next one. A 49-year-old female presented at the hospital with nausea and vomiting. CT scan of the abdomen demonstrated gastric and duodenal masses and retroperitoneal lymph node. She underwent a retroperitoneal lymph node, gastric body, antrum, and duodenal biopsy. And this is easy. So we have a lymphoid infiltrate. They look fairly monomorphic. They have nucleolus, multiple nucleolus, big cells, monotonous, ugly, nuclear membrane irregularity is there. And this is another focus. This is another area in lobar. 20 few scattered cells at 20 positive. 3 again, some are 3 positive, a majority are 3 negative. These are all 45 positive. MPO, those granulocytes with the residual present in the epithelium, they are positive, and some inside the vessels. PAX5 was strong. Nuclear, 79A was positive, 79A. Some cells are 34 positive. Ki67 is about 70%. 10, every single cell is 10, Christmas tree. 99 is positive. TDT positive. So diagnosis. There is no phenotypic aberrancy. It was identified using the stains for 5, 7, 2, 4, 8. The infiltrate was negative for BCL6, cyclin D1, myeloperoxidase, lysozyme 117 and 68. Peripheral blood and bone marrow negative for blast. What is the diagnosis?
BLBL.
Yes. And it was negative for BCR-ABL. Next one is the male in his late 80s with a left-sided neck mass. I'll probably skip this one. I'm not a cytologist, and these are all difficult cytology slides. There's a woman in her 80s with a bowel obstruction and presented 2 weeks of intermittent generalized abdominal pain. Symptoms worsened over 48 hours with no bowel movement, severe pain and nausea, vomiting. And patient admitted to the emergency department with abdominal distension and tenderness with obstructive symptoms. A CT scan done at the emergency showed a high-grade bowel obstruction secondary to a cecal mass, and the patient underwent an emergency ileocolic resection, and intraoperatively there was an interception at the ileocecal valve. So this is the mass. It's like a polyp. So it was a 5.5 centimeter rubbery tan polypod mass in the ileocecal area, and the cut surfaces they appear to involve the submucosa. This is the muscle here, so it is kind of expanding the submucosa. With displacement of the overlying mucosa, it has a fleshy look. The remaining of the terminal ileum colon are uninvolved and are grossly normal. So this is the mucosa, this is the muscularis mucosae, and this is the lesion. It is kind of going through the muscularis mucosae to the lamina propria as well. and it has a little mottled kind of appearance, not very much mottled, but we have nodules, juxtaposed nodules of various sizes, some pale areas and some dark lines going in between here. Most of the cells, they have nuclear membrane regularity, some with smooth contoured nuclei. They're basically small cells, little intermediate, not big. Any thought? What should be
Mantle cell lymphoma.
What should be our first panel?
CD23, 23, 5, SOX11.
You want to do everything in the first go?
So generally that is how we are
We
doing.
do it. What do you think about we are living in a resource limited country when the patient have no money to afford the surgery or anything, and we are kind of pouring antibodies. So you want to be a little judicious and spend like 2 days or 3-4 days to come to a diagnosis rather than putting everything in the first day and having issues. I would do a T and a B marker with a Ki67 and a 5 and a 23 to begin with. Okay, let's see. I'm not go over the flow. The flow of this case was different. I mean, we have a kappa light chain restricted B cell population, which are 19 positive, 5 positive, 23 negative, FM7 negative, and 20 with a moderate intensity, which is very important. And the T cell population is heterogeneous. And on IHC, there are 20 positive cells. They are scattered 3 bystander cells, 23 was rare positive, BCL2 positive, BCL6 negative, 10 negative, and KI is about 50%. So what is the next? I mean, I have the liberty to do all the stains, but most of the centers they do not have. We do a lot of stains here. So I mean, forget about me or where I work. The people coming, they have the money to pay, but most of the places is difficult in our country. So what is the next marker?
I think it's safe to go with a cyclin D1 or SOX11 now, with a 10 negative and 23
This
negative
is cyclin D1.
scenario.
This is your cyclin D1. So they are strongly positive for 20, 5 positive, 10 negative, BCL6 negative, 23 negative, FMC7 positive, 43 positive, BCL2 positive. Nearly all cases explain cyclin D1 and SOX11. So when you have 11-14 translocation with the rearrangement of CCNT1 and immunoglobulin heavy chain, which can be detected by conventional cytogenetics, FISH, or by Southern blotting, or by PCR-based technique to look for the transcript. And so this is something I just want to go over with all of you, not with the lymphoma experts. Pulkit, you are like barred from this discussion, so I'm just focusing for others. So the naive B cells, they carry 11-14 translocation. They colonize the mantle zone of the lymphoid polyp, which is just next to the germinal center, and they generate an in situ MCL lesion, that is an in situ mantle cell lymphoma lesion. Most of the mantle cell lymphomas, they evolve from these cells in the marginal zone with no or limited immunoglobulin heavy chain, B somatic rearrangements, and SOX11 expression. The SOX11 overexpression in conventional mantle cell lymphoma may block the cells in a mature B cell stage, preventing their further differentiation through the SOX11, PAX5, and the lymph regulatory axis. Alternatively, some of the cells with the 11-14 may enter the germinal center and they undergo somatic hypermutation, and they lack SOX11. So some of these mantle cells, they do have their negative, there can be SOX11 negative. So a classic mantle cell will go through a SOX11 positive unmuted cells, whereas with a B cell differentiation block, but the cases which are hypermutated and they can survive through the germinal center, that they become non-nodal leukemic splenic and plasmablast-like MCLs, and they are SOX11 negative. Is it clear? Did I explain properly, Pulkit?
Obviously. Yeah, only the straight point is when you have a asymptomatic leukocytosis and the flow turns out to be mantle cell lymphoma, then you think of this leukemic non-nodal mantle
Right.
cell lymphoma, and when there is a nodal involvement, then it's a nodal type is SOX11 positivity.
Because the second one in the bottom is more of a flow cytometric disease. You got it in the.
Yeah, it
in
is
the-
just
in
like
the-
a CLL thing.
It's a CLL thing, and the top one is a nodal thing. So this, the bottom one is a non-nodal leukemic pattern of disease, and otherwise it's more of a lymphoma type disease. So now coming to the next one is a area of women referred to the hospital because of acute deterioration of memory and orientation with a weakness in the left leg. She developed severe neuropsychiatric deficit, auditory and visual hallucinations. Past medical history was uneventful. MRs was atypical. Small number of patchy periventricular lesions and small areas of abnormally increased T2 signal intensity in the temporal occipital region of the right hemisphere. Electroencephalograms would implement of the vigilance with subcortical disturbances. No stenosis of the cerebral vessels were evident by Doppler and duplex. Cerebrospinal fluid evidence of breakdown in the integrity of the blood-brain barrier with elevated protein and slight pleocytosis. No skin changes. Clinically, a viral encephalitis was suspected. The patient was hospitalized and developed thrombosis, died of massive pulmonary thromboemboli. Autopsy revealed a slight edema of the cerebrum without macroscopically detectable foci. This is the brain. What are these structures? This was from my thesis. Not this case is not from my thesis, but I saw this when I was doing my thesis, my dissertation during my MD. So what are these structures? In old age, you see this corpora amylosia, the polyglucosan bodies, they're present next to the PL blood vessels and the meningeal blood vessels just below it, below the meninges. And this is a vessel which is clogged with these B cells. These cells are positive for CD20. Ki is high. What are these structures? This is not from this case. This case had these things, but this is from my thesis, age-old thesis from 1999. So what are these structures? Who can see what are these structures? This is the space of Walker Robin, and we have this vessel with some eosinophilic material. It's an old patient, and we have these star-like structures in the parenchyma, in the gray matter. These are amyloid plaques, and this is congophilic substance which is deposited next to the amyloid next to the vessel, and these are all the beta amyloid state. So this patient had, and this patient also had amyloid-like material surrounding the thing. So it's an angiotropic lymphoma with cerebrovascular amyloidosis. So we found cerebrovascular beta amyloidosis is small parenchymal bleed that might be contributed to the clinical course of these patients, while some other lymphomas such as myeloma are known to be accompanied by pathologic production of amyloid, not reported till date when we saw this case in DLBCL or angiotropic lymphomas. Therefore, it is likely that the patient present lymphoma and the cerebrovascular amyloidosis are coincidental finding without a specific pathogenic connection. Given the elevated susceptibility of these vessels, which are more fragile and they tend to rupture, the presence of cerebral angiopathy, amyloid angiopathy in patients with angiotropic lymphoma could increase the incidence of parenchymal microbleeds and exacerbate and complicate the CNS manifestations of these patients. I'll do this. So this one, the last one I'll do. Then we'll finish the 60-year-old woman with the multiple subcortical infarct. The white area, subcortical infarcts in a 60-year-old woman. This is the infarct in the center, and this is the normal parenchyma. And this is another vessel. There is a lot of fibrin, there is a thrombus, and the wall as well as the lumen and the periphery, they're infiltrated by uninucleated hypochromatic cells. And if you see this, this is the sulcus and this is the pia, and just below the pia, the vessels are kind of clogged with these blue cells. Yeah, a lot of them. Irregular nuclear membrane, convolution, heterogeneity in their size. There's some small, some big. -20 negative, 3 positive. These are positive for granzyme B, and this is TIA. This is Ibarish, and the negative for 30, ALK1 and EMA. 8 positive, 5 and 7 positive with loss of 2 and 4. Ki67 labeled those cells, and 56 was positive. 56 was positive, 57 was negative. So in an intravascular NK T-cell lymphoma with associated multifocal microinfarcts. So any question so far from the cases?
Was blood picture available in the last case just to rule out aggressive NK cell leukemia?
Yeah, the last case, you mean this one, the NK T cells?
Yes.
There was anemia. The patient was having microcytic hypochromic anemia with low iron and all, but WBC count and the platelet were normal.
Okay.
That's a great question, because you were thinking like, is it like an aggressive phenotype of the disease and involving the...
Yeah, sometimes aggressive NK cell leukemias can involve the
brain. Yeah. So we kind of termed it as an intravascular NK T cell lymphoma instead of writing like a leukemia, as you say, they're more aggressive and they have a systemic dissemination.
Yes.
I kind of pulled a lot of cases, but it's kind of impossible to go over everything, and because there'll be a lot of hodgepodge, then because we need to like understand and do things. Thought probably I'll do like 8 or 10 cases, then maybe subsequently we can do more. Any question in the group, in the WhatsApp group, or sorry, in the YouTube or?
In the YouTube, there are 2 comments. One is, I'm not very clear about the name, so I will just read it out the comment. Plasma cell neoplasm can be CD3 positive. It has been reported.
Yeah, it has been reported. That I am Pulkit discussing. There are reports which are 3 positive, but our question is, because it is a lineage associated marker, a lineage marker, or a lineage specific marker, aberrance is rare in those markers. So
yeah.
Basically,
another
do not
comment, another comment in the same, in this particular case was, what about the c-mix status?
That I have to check. I do not even know if they have done it or not, the c-mix, in that particular case.
Okay.
Another thing I've forgotten to tell you, I didn't have a picture for that ALK positive DLBCL. That case was strongly c-mix positive. Almost 80% of the cells were c-mix positive. An immunohistochemistry. And we did send the tissue for BCL2, BCL6, and c-mix for the BRICPART studies. And c-mix was positive and the rest 2 were negative. I mean the translocation. In all my all our high-grade B-cell lymphomas, I do send it for BCL2, BCL6, and c-mix. If the patient can afford, I mean, at least we write down in the bottom part of the report in the comment.
Yeah, Dr. Sambit, yeah, I would like to know that you are performing flow in all such suspected cases of lymphomas in tissue.
No, not all. I mean, we do triage the tissue because we get the fresh lymph nodes when we get it. So we have a team, they call us, and whenever they're doing a lymph node excision, they call us. So we go. I mean, my resident, my fellow usually go and get the thing because we take the fresh tissue. But whenever we need it or we have a question or some cases the upfront bill it because in corporate setup is everything all about money. So the bill it, then we go for a flow, a lymphoma. Not
And regarding the IGS and TCR study,
that's in a very small subset. That's in a very small subset of cases, not in all. I mean, in US, yeah. And in the US, we used to do in almost all the cases. Flow, then tissue, IHC, and molecular. They all are integrated, and I tried that. It's always not possible. I would say probably out of 100 cases, 10 will turn out to be everything. 10 may be more optimistic also. It's like 5 to 10 cases will turn out to be everything. But things at least nowadays it's kind of, if you have a flow and everything with you, then you feel more confident signing out the cases of at least we release the report with histology and immunohistochemistry, and we release another report as an addendum once we have other findings available with us, the molecular.
There is another comment with the same doctor, so is mantle cell lymphoma in this case.
Yeah, that was a mantle cell.
Very, very nice cases, brilliant.
Sir, one more query. Another differential diagnosis in that ALK positive could have been HHV8 associated DLBCL. So,
yes.
Have you in your practice got such case? And
no, I have never seen. I've only seen in conferences and in the book. I've never seen in my practice HSV8 positive DLBCL. What is your experience, Pulkit, on that?
No, we also haven't seen those such cases. We tried hunting for those cases in such scenarios, but we didn't had the ALK positive DLBCL and also the HHV8. So these are pretty rare conditions and just described in books.
The ALK positive DLBCL. So there is a subset which expresses in HSV8, right? In ALK positive DLBCL, right?
Yeah. And what clone for ALK you use for this? You use the routine or D5S that thing?
No, D5S. Vendana. We use the Vendana.
Okay. Thank you, sir.
You're welcome. But that's a good point. I mean, we have the block and can do like this HHB. I just sent out like today. आज ही उसको report किया हूँ मैंने. So I thought we take some pictures.
You can try.
Yeah. I can send you the block. You can do HHB for me.
Sure.
Lymphoma is a huge topic, and I mean there's so many cases and a lot of like everything is becoming so complex in every organ system, and lymphoma is the most complicated area. I feel the more and more you read, you are like lost. But the thing is, basic morphology is very important. I mean, the reactive lymph node. I did not put any reactive lymph node today, but reactive lymph node is the most common. I mean, the difficult area, and the second is diagnosing something on a core biopsy which is not uniform. If you have a uniform cell population in core biopsy, it is little easier. I would not say it is very, very easy. But if you have a heterogeneous population in a core biopsy, it is like a nightmare. And giving a heroic diagnosis of lymphoma in a core biopsy is difficult. Once we have a big lymph node, it's probably not a big deal. But when you have a core biopsy, it is difficult. What is the opinion on core biopsies, Pulkit? Are you very comfortable on core biopsies?
Yeah, sometimes when we have a straightforward defining marker on our core biopsy, we do give, but especially in cases of T cell lymphomas and
Yeah.
all, or
The
DD between
Huh.
reactive lymphadenitis versus a T cell lymphoma versus a T cell rich B cell lymphoma, we get stuck, and then we correlate, then we discuss in the lymphoma rounds, and then we ask for some more samples.
Samples, yeah. Because sometimes it's very difficult for the surgeon also to get a proper lymph node out because they're like stuck next to a vessel. So in that time, if you have a polymorphic lymphoma, specifically as Pulkit said, T cell rich B cell lymphoma, or you have any sort of a T cell lymphomas and reactive lymph node, sometimes this thing has gone through a follicular center. So you see all big cells, and you tend to do like CD30, the positive. You say like, oh, I'm dealing with Hodgkin. Or you get some B cells and you see very high Ki67. So those kind of things. So I feel in a core biopsy, when you do not have a defining marker and the morphology is not very classical, you basically have to have a consensus opinion in the department as well as with your clinical counterpart, and look into LDH does help in that case, and how long the history, what are the other sites of involvement, multiplicity of the lymph node involvement, multifocal involvement, those things really help in those scenarios. But core biopsies are like, we usually get the core biopsies. I mean, excisions versus core biopsies, they're kind of half and half. Anybody wants to give like other input on this? Because there's so many people in the group. Because like centers like PGI, where we all are working, is more like we have immuno setup. Because when there is no immuno setup, what is your take-home message, Pulkit? Because you do a lot of cases of lymphoma. I mean, when you have no immuno setup, I mean, the immuno setup is very, very minimal, like 3-4 stains, suppose you have available. Because in the rest of the country, I mean, it's not like everywhere you have all the markers.
Yeah. So initially, we have our own sort of panel, you can say, because we also have resource constraints. We initially go with a CD3, CD20, and CD30 in all cases, irrespective of whether you are seeing the large cells or not. Because CD30 is really a good stain for the lymphoma, for Hodgkin's, and then we do the second panel. And it's a golden thing. If you have a core biopsy, always ask for a further coated sections, unstained sections, so as to save the tissue. So because these are the precious tissues.
Right, that's a very good question. Suppose you have a lung core, breast core, lymph node core, and especially a lymph node core. Tell your technicians to have at least 10 unstained polylysin coated slide ready for you when they are trimming the tissue. Because if they're going to cut it the next day, they're going to trim and lose a lot of tissue. So you need like 11 sections up front, one for H&E, and the rest they keep it expecting an immuno workup.
And definitely, and don't hesitate to ask for an opinion from your colleague.
Exactly.
Yeah, definitely. Rather than wasting a tissue on some. Yeah.
So I said knock stain and telephone stain. What is knock stain? You knock your friend's door and say, hey, can you help me with this case? That's the best thing. And number two, if both of you or three of you cannot reach to a conclusion, have a telephone stain. Call your clinical counterpart and ask for help. Asking for help in pathology is a credit. It is not a discredit.
Definitely. And especially you should also be somewhat familiar with the PET scan reporting, because your SUV uptake helps sometimes, because especially in a reactive versus a high grade thing.
Reactive versus low grade versus high grade, because reactive and low grade, they have a similar SUV max, but a high grade you usually have a high, and what is the contour of the lesion and all. So PET, if it is available, it is very, very important.
Definitely.
Unlike the other solid organ malignancies where you can get away without knowing the radiology to some extent, lymphoma is more of a clinical, imaging, and pathologic diagnosis. I just want to emphasize that at the end of my talk. You need to know the clinical very well for lymphoma.
Yeah. Very interesting discussion. I think we have to close here.
Great, thank you.
Very nice, very, very interesting cases, very, very, very nice discussion. Lot of doubts cleared, lot of new things, learned. And we have a very nice panel, and I can see some of the people who will be coming in to talk. Dr. Pulkit has a talk on the differential diagnosis of Hodgkin's lymphoma, specifically the RS cell, next month. And we have also Dr. Manasi also in the panel. Neeraj Dhameja is also there to be speaking soon. So we've got a lot of people here who would be talking. Thank you.
Right.
Thank you everybody for joining. Thank you everybody for joining on the YouTube. We've got a big team there listening to us. Thank you so much. Dr. Sambit, once again, thank you for coming onto this platform
Thank you, Dada.
and sharing your excellent knowledge on these subjects. Thank you, Dr. Pulke, Dr. Shilpi, Dr. Manasi, Dr. Rajiv Shukla.
Hey, Rajiv is there.
Yeah, he was just trying to knock
Can
you.
I say hi to him?
Talk to him straight away. Hi, Rajiv.
Oh.
Hi, Sambit. I was
Hey,
just
Rajiv.
between
Hi,
in and
hi,
out.
how
Just
are
wanted
you?
to say hello.
Hi, how are you? I'm going to call you.
I am good.
As soon as
Long
as
time,
soon as the
man.
talk is over, I'm going to call you.
Yes, yeah. I just want to tell the audience that I passed my MD exam listening to Sambit. So
Oh,
he used
don't
to go
tell
to
me.
lab.
Please.
And
No.
then
I always say I passed my exam because of Rajiv Shukla. Everyone knows. In US and in India, everyone know I got my MD. I owe my MD degree to you, Rajiv. Because I was
Come on.
extremely lazy. You read and I used to sleep and listen to that.
good. Nice to speak to you later.
Okay, cool.
Hi, Dr. Rajiv. How are you?
Good, Sarah. How are you?
I'm fine. Yes, we are trying to defend ourselves from this second wave of COVID. Just trying
I
to work
know.
ourselves.
There's so many people. I know they
Yeah.
restricted the mobility, right? You cannot.
We also have Dr. Arvind Gulati here, Dr. Kirti Gupta, Dr. O.P. Gaming, and so many of them. Thank you so much for joining. Okay, take care. Bye-bye. Good night.
Thank you. Good night.
Bye. Bye.